Good evening, everyone, and welcome to the webinar on the theme How to Make Sense of GI Cancer Data in ESMO 2025. It gives me great pleasure to invite our Program Director, Dr. Amol Akhade, Medical Oncologist from Fortis Cancer Institute, Mumbai, India. Over to you, sir.
So, welcome all. I first of all thank my faculty for joining from across the globe. And without wasting much time, we will start with the first lecture. And it is by Dr. Saphalta. She is Senior Consultant and Associate Professor at Department of Medical Oncology, Amrita Hospital, Faridabad. And she will be talking about what's new for upper GI and hepatobiliary. So, Saphalta, over to you.
Thank you, Dr. Amol, for having me here. I'll be talking about the updates of ESMO 25 GI cancers. So, just a minute. So, these are the clinical trials I'll be discussing in the subsequent slides. First, we'll discuss about HCCs. So, CARE 009, this is the first phase 3 randomized trial in a perioperative setting in which pembrolizumab and rivaroxaban were investigated as were compared with surgery alone in patients who are having resectable hepatocellular carcinoma and having intermediate or high risk of recurrence. So this combination has been previously tried in metastatic setting and is what compared with sorafenib where it has shown an OS benefit. So now they are—
The slides are not visible, Saphalta.
So just a minute. I have been sharing it. Is it visible now?
Yes, ma'am.
Okay. Sorry. So they included patients of Chinese liver cancer staging because these two drugs are from China. And they included patients of 1B, 2A, 2B, 3A, and which corroborated with the BCLC stage A, single tumor with more than 5 centimeter, or BCLC B. Just a minute. BCLC B and BCLC stage C. And the here the patient, in control arm patient underwent surgery and followed by the active surveillance, which is now presently the standard of care. While the experimental group, the patient received 2 cycles of the combination drug followed by surgery and then 15 doses of the combination treatment. The primary endpoint was EFS by investigators. The key secondary endpoint were OS and major pathological response. Secondary endpoints were R0 resection, pathological CR rates, and EFS and DFS by the review committee. Now, at the median follow-up of 21.3 months, here we can see that it has shown significantly better EFS as compared to surgery, 42 months versus 19.4 months. Hazards were 0.59. So it has shown really meaningful benefit. And in all the subgroup, it has shown benefit. So what is important about this CARE 009? This was a immunotherapy study in early stage HCC. It was a perioperative setting and first phase 3 study, which is positive. But will we change our practice based on this study? Likely in China, yes. But for us, maybe not. Why? We'll see this in subsequent slide. So this slide shows its comparison with Matterhorn study, which we consider it as a practice changing study. The Matterhorn study, the hazards were 0.71, 0.70, but where in CARES, it is hazards were 0.63. So it was quite impressive. But then also we are questioning it. Why? So here you can see that the pathological CR rate was 3.4%. So it has some activity, but it has not shown that the pathological CR rate were not lower. So maybe the number of cycles they could have given before surgery more than 2 cycles. It can be 4 or 6 cycles. And another point you can see here, that is the patients who completed this adjuvant treatment. That is only 20% of the patients. So there were so many dropouts after that. So likely we can restrict our dosing rather than giving full 15 doses. We can restrict to lower number of cycles. First 4 to 6 cycles before surgery and followed by surgery, and then 4 to 6 cycles post surgery. That could have been a better trial design. Another aspect we can see in this study is there were almost 50% of the patients who were beyond up to 7 criteria. And there were many patients where we will not consider surgery as a treatment of choice. We will consider TACE along with systemic therapy, either it can be IO or TKI, and that would have been given better PFS. So in international study, the control arm would have been different. Coming to the next study, that is I Am Brave 152 or Skyscraper 14 study. Here, they investigated tiragolumab plus atizo-bev combination, and it was compared with the standard of care atizo and bev. So this is a very good study that they compared it with atizo-bev. Usually, most of the studies, they compare with sorafenib. Now, what is tiragolumab? Tiragolumab is an anti-TIGIT inhibitor, and TIGIT is a co-inhibitory receptor and immune checkpoint, which is there in NK cell, T cells, Treg cells, and is implicated in many of the malignancies, including HCC. And it shows, and it has shown that it enhances the activity of atizo. And so that's what it was thought, and it was studied. And there was one phase 1B and 2 trial which evaluated this combination, and it has shown some benefit. So now this is a phase 3 randomized trial, and the setting was similar, and patients were all the patients were child A. The primary endpoint was investigator assessed PFS and OS, while secondary endpoints were the response rates and the safety and patient-related outcomes. But here you can see that adding third drug did not show any benefit. And a p-value was 0.7, hazards were 0.97. So I Am Brave 152, what is important about this study, that it was a first phase 3 study which tested triplet regimen advanced SCC, and it was first phase 3 readout at on anti-TIGIT, but unfortunately negative. So we may think of, there were some thought process that maybe there's fallacious trial design or there's some bad luck, but trial design was good, but bad luck we'll see in subsequent slide. So coming to esophagus, here also there is one skyscraper study 07. Here also tiragolumab was added to atizo, and it was tested in unresectable esophageal squamous cell carcinomas, which has not progressed after definitive CTRT. So right now, our treatment choice is definitive CTRT in the unresectable locally advanced esophageal squamous cell carcinoma, and followed by that, what we do is we do surveillance. Here, this study tested one arm, that is placebo, which is like standard of care, giving nothing. Another arm that evaluated addition of atizo plus placebo, and third arm added tiragolumab on with atizo. The primary endpoint was to see the combination, compare this combination with placebo, and in the terms of PFS and OS. Now, coming to the data result, the study result, here you can see if these patients who underwent CTRT, definitive CTRT, they have shown significantly better PFS as well as OS. So that this study is one of the landmark study which can be practice changing, that post CTRT, like we used to give an NACTRT followed by surgery, and if there is a residual disease, we give nivolumab. So here also, patients who are undergoing definitive CTRT, atizo can be a drug that can be given in the adjuvant setting. Now, coming to the result of adding tiragolumab. Tiragolumab did not do well, and in fact, the patient who received the combination, they did worse as compared to that of the placebo. So from this study, we got one important drug, that is atizo, that can be given post definitive CTRT, and tiragolumab is not the drug that can be tested in this setting. So probably the drug, if researchers want to use the drug tiragolumab, so in that case they have to plan some other study. And it was not a bad luck, it did not work well with atizo, and probably they have to find some other partner. Coming to another study, that is lenvatinib plus pembro and chemotherapy combination. Here the addition of lenvatinib was tested in metastatic esophageal squamous cell carcinoma. In this study, the authors have suggested that Pembro and Lenva, it worked in RCC, it worked in endometrial carcinomas. So they tested this in squamous cell esophageal squamous cell carcinoma, and in a previous study, LEAP-015. So it has shown some response. So they tested in this phase 3 randomized trial. So the patients, they receive the chemotherapy along with Pembro plus lenvatinib as an induction, and followed by that maintenance of Lenva and Pembro. And there was no benefit of adding lenvatinib in these patients. There was no OS benefit, no PFS benefit, even in the patients who are having CPS score more than 10. Now, Matterhorn study, which is a practice-changing trial, and we have been talking about this trial for last 2 years, and they have presented their final overall survival in ESMO 25. So 2 cycles of chemotherapy along with immunotherapy was given before surgery, and then 2 surgery followed by 2 doses followed by surgery. So OS data was presented in ESCO and now in ESMO, and the median duration of follow-up was 34 months during ESCO time. It is now 43 months, and then the hazards have remained same, 0.78 and 0.78. So it was a consistent study, consistent result, and it has shown an OS benefit. So in last 2 decades, when compared to surgery, where the 2-year OS was 41%, we have reached to 75.5% with durvalumab plus FLOT. And in 3 years, the difference between the placebo plus FLOT versus durvalumab addition was 6.7% benefit. With that, we have significantly increased the survival in G junction tumors, stomach cancers along with FLOT. So to conclude, CARES, it included, it did a perioperative IO plus TKI combination. It may be useful in some certain subset of patients. IM Brave 152 was totally a negative style. There is no role of tiragolumab. There is no role of tiragolumab in esophageal cancers as well, though Atizo is one of the drug that can be thought of, and it can be a practice-changing post-definitive CTRT in esophageal cancers. Addition of lenvatinib did not show any benefit in esophageal cancers along when it is added to Pembro and chemotherapy. And Matterhorn study, which showed that durvalumab plus FLOT has significantly better OS as compared to FLOT. Thank you. Thank you, Erman.
So thank you, Dr. Saphalta, for this wonderful and crisp presentation. And thanks for finishing on time. So I appreciate that. And let's move on to our next speaker. So we have Dr. Sawyer. He is a hemato-oncology fellow from Darcy Cancer Institute, Cleveland Clinic, and he will be talking about what's new for lower GI and neuroendocrine tumor. Over to you, Dr. Sawyer. Can you, you're not audible. I think you have to unmute yourself.
Oh, can you hear me?
Yeah.
Okay. Can you see my slides right now?
Yes, we can see your slides. You have to make them full screen, slideshow.
Yeah.
Yep.
All right, so you can see it?
That's good. Yeah.
All right, perfect. All right, hi everyone, my name is Sawyer, and I'll be discussing ESMO 2025 highlights for lower GI and NET. So the first study we have is Stellar 303, which is a phase 3 study that looked at zanzalintinib plus atezolizumab versus regorafenib in patients with previously treated metastatic colorectal cancer. In metastatic colorectal cancer, immunotherapy has made a significant difference in MSI high disease. However, in MSI stable disease, immunotherapy has not been seen to make much of a difference. This is what was being analyzed in Stellar 303 in refractory MSI stable colorectal cancer, where they analyzed a combination of zanzalintinib, which is a multi-targeting tyrosine kinase inhibitor, and atezo versus regorafenib.
So sorry
So
to
as
interrupt
shown,
you, sir. So could you try making your slides into presentation mode, sir?
Yep.
Perfect.
Is that,
Thank you.
that's better? Okay. Okay. So as shown, patients were randomized 1-to-1 for Zanza and Atezo arm compared to regorafenib. And this had dual primary endpoint of overall survival and intention to treat analysis, as well as overall survival in patients without liver metastasis. And key secondary endpoints were progression-free survival, ORR, and safety. And of note, approximately 80% of patients received prior VEGF therapy. So the primary endpoint was achieved with statistically improved overall survival of 10.9 months for those treated with a combination of Zanza and Tezo, compared to 9.4 months for regorafenib. And this had a hazard ratio of 0.80. And the median progression-free survival was also improved from 2 months to 3.7 months in the intention to treat population. So the intention to treat population, patients without liver metastasis had a median overall survival of 15.9 months compared to 12.7 months for regorafenib alone. This overall did not meet statistically significant significance, but it was a smaller subgroup of patients. Looking at the safety overview, the number of grade 3 treatment-related adverse events was 56% in the treatment arm compared to 33% in the regorafenib arm. Importantly, there's overall 6 patients that died in the treatment arm, including 2 with intestinal perforation, 1 with pneumonitis, and 1 with renal failure, compared to the 1 in the regorafenib arm. Safety for this regimen was consistent, though, with prior ICI VEGF TKI combinations with no new safety signals emerging. And most adverse events were grade 3 or less, managed with dose modifications. So in conclusion, the Zanza plus Atezo arm reached primary endpoint as it significantly improved overall survival. So overall, this was a positive study. It was the first time we have seen an IO-based combination regimen having overall survival benefit in microsatellite stable metastatic colorectal cancer. This has long been resistant to immunotherapy. The safety regimen was consistent with no reported new safety signals emerging. However, the grade 3 treatment-related adverse events was 56 compared to 33%. These were typically the things you would expect for the combination of multi-targeting TKIs and immunotherapy. However, in the real world, we might be able to improve tolerability by using dose adjustments. So overall, the Stellar 303 showed Zanza plus Atezo is a potential new chemotherapy-free treatment option for heavily pretreated individuals with metastatic colorectal cancer. All right, so moving on, we have comparison of outcomes in clinical trials of locally advanced DMMR colon cancer, which is data from Foxtrot and NICHE-2 trials. In locally advanced DMMR colon cancer, the standard therapy is upfront surgery, then oxaliplatin-based chemotherapy. In DMMR metastatic colorectal cancer, the use of immunotherapy, IO without chemotherapy, has been paradigm changing. The ATOMIC trial had demonstrated DFS benefit from the addition of Atezo to adjuvant oxaliplatin and 5-FU in DMMR locally advanced colon cancer. So this data helps compare a data set of patients who were treated with neoadjuvant chemotherapy in Foxtrot compared to neoadjuvant immunotherapy in the NICHE-2 trial. So Foxtrot analyzed patients with clinical T3 or higher or clinical node 0 to 2 without metastatic disease or obstruction, and they're randomized to get perioperative FOLFOX or surgery, followed by adjuvant FOLFOX. Similar NICHE-2 analyzed patients with T3 or higher or clinical node positive confirmed DMMR MSI high status. Patients received Nivo at 3 mg per kg and plus IPI 1 mg per kg, followed by 2 weeks later with Nivo 3 mg per kg, followed by surgery. In comparing patients with mismatch deficient or MSI high status, there's a pretty drastic difference. At 3 years, the DFS was 100% in the NICHE-2 study, indicating improved DFS with Ipi-Nivo combination compared to Foxtrot, which used FOLFOX with the DFS of 80%. The Ipi-Nivo combination was also superior for disease-free survival in the straight to surgery Foxtrot population as well. And also, as shown here, niche 2 showed a higher complete TRG, 1 at 72.3%. So the key takeaway is that neoadjuvant nivo plus IPI resulted in statistically and clinically meaningful improvements in long-term outcomes compared with chemotherapy strategies. And the highest gains with neoadjuvant immunotherapy were clinically staged high-risk CT4 patients. All right, the next study we have is the Breakwater, the ctDNA analysis of BRAF V600E dynamics and changes in genomic landscape in patients with first-line BRAF V600E mutant metastatic colorectal cancer. So BRAF V600E mutation defines biologically aggressive metastatic colorectal cancer subset with historically poor outcomes under standard therapy. The phase 3 portion of Breakwater met both its dual primary endpoints and key secondary endpoints with improvements in ORR, PFS, and overall survival. The EC plus mFOLFOX received accelerated approval as first molecularly targeted regimen for untreated BRAF V600E mutant metastatic colorectal cancer. And this study presented at ESMO aimed to understand how early molecular changes correlate with clinical benefit and how resistant mutations have emerged under therapy. So baseline plasma samples were available for 96% of patients and had BRAF V600 ctDNA was detected in 86% of patients with a high concordance of 87.4% between ctDNA and tumor tissue testing. Clinical benefit was seen with the EC plus FOLFOX across VAF high and VAF low groups, and showing that ORR and survival benefits for EC and FOLFOX was independent of the baseline BRAF V600 VAF status. Thus, adding mFOLFOX to targeted immunotherapy improved outcomes regardless of baseline ctDNA burden. So patients whose BRAF V600 mutation became undetectable in ctDNA at cycle 2 experienced notably longer overall survival compared to persistent detection. The hazard ratio for overall survival is 0.30 for EC plus mFOLFOX compared to 0.36 for EC and 0.50 for the control arm. And proportion of ctDNA clearance was highest with EC FOLFOX, 67% compared to 45% EC and 38% for the control. So in conclusion, the big takeaway is that we have been questioning if there's a strong rationale to go for EC plus mFOLFOX over EC alone. It's clear that chemo helps prolong benefit of EC by relative reduction in the emergence of acquired alterations that may potentially confer resistance to EC. And also across molecular subgroups, EC and mFOLFOX achieve higher response rates, more favorable overall survival, hazard ratio, and demonstrate enhanced ctDNA clearance with fewer required alterations, supporting enhanced therapeutic effect of targeted therapy and cytotoxic chemotherapy. Next study we have is Dynamic 3 that analyzed ctDNA-guided adjuvant chemotherapy de-escalation in stage 3 colon cancer. So ctDNA has been rapidly evolving. It's largely been used as a prognostic tool compared to a predictive tool, with previous studies have not been able to demonstrate its predictive role in de-escalation or escalation. And Dynamic 3 explored ctDNA management of resected stage 3 colon cancer with postoperative ctDNA negative treatment de-escalation versus the standard of care. So patients were randomized less than 6 weeks from surgery, or patients were evaluated less than 6 weeks from surgery and randomized 1-to-1. Patients with ctDNA negative status had de-escalated therapy, which that included either shortened chemotherapy duration from 6 to 3 months, reduced intensity of a doublet to ciclate agent fluoropyrimidine, or observation. The primary endpoint was the 3-year recurrence-free survival with secondary endpoints of treatment adherence and safety. So there's a total of 968 patients that were evaluated, with 72.5% of patients being ctDNA negative, with a median follow-up of 47 months. As shown here, the 3-year RFS was 85.3% for ctDNA arm versus 88.1% for the standard arm, Of note, oxaliplatin use was significantly lower in the ctDNA guided management at 34.8% versus the 88.6% for standard. Clinically low-risk tumors, T1 to 3N1, de-escalated outcomes were comparable to standard therapy, suggesting that this subgroup could safely benefit from a less intensive treatment. For grade 3 adverse events were lower in the ctDNA-informed de-escalation, 6.2% compared to the 10.6%, as well as the treatment-related hospitalizations at 8.5% versus 13.2%. So overall, Dynamic 3 showed that ctDNA de-escalation sharply cuts oxaliplatin use and toxicity, but non-inferiority versus standard of care was not confirmed in this study. All right, moving on to LightSpark, which used bolsitinib in advanced pheochromocytoma and periganglioma. So PPGLs are neuroendocrine tumors of the adrenal medulla or extraadrenal periganglia. And hypoxia-inducible factor 2 alpha dysregulation is a key oncogenic driver in PPGL. Previously, HIF-2 alpha inhibitors have been successful in shrinking tumors and slowing disease progression in other cancers that are HIF-2 alpha overactive, such as renal cancer. Building on this knowledge, LightSpark evaluated the effectiveness of these inhibitors on advanced PPGL, as there is currently no available standard of care. So LightSpark 015 is a single-arm phase 2 trial that analyzed belzutifan in locally advanced or metastatic PPGL. The primary endpoint was ORR with key secondary endpoints, including duration of response, disease control, as well as OS, PFS, and safety. So overall analysis of 72 PPGL showed an ORR of 26.4%, and disease control was 84.7% with a median DOR of 20.4 months. And the median PFS was 22.3 months. Median overall survival was not reached. In regards to looking at hypertension, there's 32% of participants had a 50% or more reduction in total dose of at least one antihypertensive medication maintained for at least 6 months. So belzutifan showed clinically meaningful anti-tumor activity and durable response with a manageable safety profile in advanced PPGL. Also showed improvements in blood pressure management for a subset of patients, along with a manageable safety profile. So this data supports that belzutifan for the treatment of advanced PPGL. And last but certainly not least, study is the COMPETE trial. Looked at efficacy, safety, and subgroup analysis of etotropium versus everolimus patients with grade 1 or grade 2 GEP NETs. So etotropium is a radiolabeled SSTR ligand, which is developed from radiopharmaceutical therapy for treatment of SSTR-positive tumors. COMPETE is the first phase 3 trial comparing radiopharmaceutical therapy as monotherapy with an improved target therapy in first or second line patients with grade 1 or grade 2 GEP NETs. So it's a prospective randomized controlled multi-center phase 3 trial looking at grade 1 or 2 unresectable or metastatic progressive SSTR positive disease. Individuals included those who were treatment naive or who had progressed under prior therapy. And the study was randomized 2-to-1 with a primary endpoint looking at PFS. The trial met its primary endpoint with the median PFS being significantly longer for etotropium arm at 23.9 months compared to 14.1 months for everolimus arm with a hazard ratio of 0.67. So the major takeaway for this study is that the first randomized phase 3 trial showing radioligand is better in terms of delaying disease progression in NETs compared to other modalities of therapy, in this case evaluating at everolimus. It met primary endpoint of PFS, also key secondary endpoints of central and local ORR, and even had better safety profile supporting its potential as first or second line treatment option for patients with GEP NETs. All right, thank you.
So thank you. Thanks for this wonderful presentation. And I think we will move on to the panel discussion. And I will share my slides. And let me welcome my panelist, Dr. Nina Sanford, and Dr. Udhayvir Grewal, Dr. Amalya Sargsyan, Dr. Erman, Akkus, and Dr. Anant. Dr. Pashtun unfortunately could not join us because of some issues. So moving on, let me share, I think, Sawyer, you have to stop sharing so that I can share my slides. Can you unshare yourself?
Sir, I want to share the screen.
Yeah, fine. So are my slides visible?
Yes,
I
sir.
hope
Yes,
it is in full screen. So
yes,
let
sir.
me start. I have no conflict of interest. I thank all my faculty who have joined from across the globe and managing the different time zones. I really appreciate them and thank them. Let us understand, aim of this discussion is to make sense of GI cancer data for clinical use on Monday morning in clinics. We are not here to find faults in the clinical trials. We appreciate all the hard work that goes in doing clinical trials and thank all patients who participate in them. So to start with, let us start with hepatocellular carcinoma. IMBRAVE 152 tested atezo plus BEV plus Styra versus standard atezo-BEV. Unfortunately, it was a negative trial, no improvement in PFS or OS. So basically it gives us another reminder that not every immune add-on translates to benefit. Now we have in this particular ESMO, we have a lot of negative trials, especially in GI. So next was LEAP 014 in metastatic esophageal squamous cell carcinoma, first line. In this phase 3 trial, they added Lenva to Pembro to standard chemotherapy versus Pembro plus chemo alone. Again, unfortunately, a negative study, no OS advantage despite encouraging phase 2 data. So what it reflects that not all phase 2 positive or encouraging data are going to give you good phase 3 results. And now moving on to the locally advanced disease, the skyscraper 7 evaluated atezo plus Tyra maintenance after definitive chemoradiation, unresectable esophageal squamous cell carcinoma. The TIGIT containing arm failed. Unfortunately, there are a lot of issues with hierarchical testing. It stopped formal significance testing, but the atezo alone arm has some hint of OS benefit. So let me invite my first faculty, Dr. Amalya. So, Dr. Amalya, what do you learn from these negative trials? It is important to present negative trials. So, what do you think? What is your overall looking message with these negative trials? Dr. Amalya, are you there?
Yes, I'm here. Can you hear me?
Yeah, I can hear you. Please.
I'm very sorry for my neighbors making noise. I'm currently traveling, but I hope we can still hear me. And it's tough starting from negative trials and understanding what is the role of discussing these things. But indeed, it's important because no negative trial teaches nothing, because we learn what not to do or how to proceed with the next and how to design further our trials. So thank you for nicely presenting the data, which was already in ESMO. And what we've seen, it's not a good year for TIGIT, I guess. Both trials, the IMBRAVE Skyscraper 14 and Skyscraper 7 were negative. But yet there were some other trials in TIGIT with dual blockage, which were positive, like gastric edge. But of course, phase 2 trial is not translating always to the phase 3, as we see here. Can I ask to go back to the slide so we can just briefly come on and a bit? Yeah. So here we had the IMBRAVE 152, which tried to test whether adding tiragolumab to what was already the standard atezolizumab will further improve, and we didn't see any benefit here. So clearly this is no for the anti-TIGIT here. And for triplets in HCC, it was not the best year, and another triplet also failed when they tried to add EP to, no, not here, but to atezolizumab. It also was negative. So what we learn here that maybe more is not always the better. So we are adding toxicity without gaining the benefit. The hypothesis that dual immune blockage with anti-TIGIT plus anti-PD-L1 is scientifically rational, and it was seen in the earlier lines that there is a hint of better response. But I think here the important part is the safety. Because of the safety concerns, which were more with tiragolumab, we might want to see additional data when it's finally published full, but people discontinued the treatment, so maybe they get less exposure to other treatments. There may delays with the treatment, which also can affect the efficacy. So it's not only giving the drug, but the deliverability of the combination. So at this point, still atezolizumab is the first line, and we also have another choices of ipi/nivo or durvalumab. So basically, TIGIT is not playing the role here. Another negative one, the LEAP study, the idea of giving VEGF TKI to the pembro and chemo, so IO chemo combo, which is already a standard of care, because we have seen how the data was consistent in the trial led to approval for IOs in esophageal squamous cell carcinoma. Unfortunately, Lenva didn't go well here. The study was negative in neither of the arms. And here again, I would stress the fact that Lenva in 20 milligram is pretty toxic, and not a lot of patients do tolerate it. And we have seen the same in the endometrial cancer and renal cancer. No one could tolerate this full, and we had a lot of dropouts and dose reductions. So we have to be thinking about it. Also, VEGF pathway, though we think that it's important, maybe this is not the point of overcoming the immunotherapy resistance. So giving another TKI on top of immuno, it will not add any benefit, because this is not the case, and maybe we'll need to find another potential pathways, and other translational research, I believe, will share more on it. And another thing might be that we could have antibodies. We have seen some responses in gastric cancer with ramucirumab, regorafenib, and I know that the trials are ongoing. Unfortunately, not a lot of good data going there, but maybe these combos, which have some effects and hints in phase 2s with regorafenib, nivolumab, and chemotherapy, might change the landscape of how we think about TKIs at first line. But clearly, for now, still IO chemo is the backbone. And the last negative one that we're gonna discuss, another TIGIT. The idea was, after consolidation, chemo-RT, to give atezo and tiragolumab. And the good thing I will leave, I will say only the bad things here, which was the primary endpoint, was to test whether both combo will improve the survival. Though we see that monotherapy did improve, give some hint, but the combo was not. And again, I believe here toxicity plays a role, and a lot of grade 3 adverse events were seen as presented at ESMO, so people get less exposure to atezolizumab, which might have more role. And what I think here might help, after chemo-RT, we are learning how to navigate with immunotherapy. Maybe bring in earlier to the lines. We are learning how to do it earlier in the settings. So basically now atezo alone will be tested, and I know that pembro trials are ongoing. We'll hear more about it, but for now, dual blockage is not playing a role here as a consolidation, at least. Or we will need something more like ctDNA testing to select and ultra-select patients and understand how to overcome resistance for the further lines. So my takeaway will be immuno has a role. Sometimes dual blockage can work, but not always. And we will have to learn how to work with TIGIT, because basically these ones are not the one we do. And the hypothesis that dual blockage is better is not working. That's it for me.
Thanks for this analysis. And there is a debate whether the TIGIT story is over or not, and probably we'll have to wait for some more data, maybe in ASCO GI or maybe next year ASCO, to understand whether that story is over or not. But moving forward, in these particular trials, CASCAPE-07, not everything was negative. In fact, in the atezo only maintenance arm, we now see an OS hazard ratio of 0.69. So is less is more? So is there anything that we can take away from this? So let us understand that it was only numerically okay, but not statistically, because of the hierarchical testing and the issues with the testing. So let me ask Dr. Anant, do you think that atezo maintenance arm is positive numerically and hence meaningful for clinical practice, or is only hypothesis generating? Dr. Anant?
Yeah, so by nature of the trial design, we can only conclude that it's, hypothesis generating, and we cannot say it's practice changing. But I think this opens up an avenue like in lung cancers, post CTRT, Durva, right? So this is very similar to that in terms of there could be benefits with an IO maintenance. And now I'm sure that people will pick up on this and do a host of trials evaluating Atezo, Durva, Pembro. Pembro is already ongoing. So I think it opens up an avenue there because till date, we've not really hit great targets with adding chemo. There was a trial from TMH adding metronomic. It has not worked. So when you have a difference in survival of 12 months or so, I think it's important to look forward at this. Though at this point, it's only hypothesis generating.
So Dr. Nina, what's your thought? Do you
Yeah,
agree with the tenant?
I think first of all, I think this is a very meaningful question that the study is asking in a patient population that definitely needs better outcomes. So first you want to think, what is the needs of this population? And we know that after definitive chemoradiation for unresectable esophageal squamous cancer, the recurrence rates are 50% or higher. So even after curative intent treatment, most patients are not cured. So I think the idea of adopting or testing a consolidative maintenance approach like Pacific, as the prior speaker alluded to, makes a lot of sense. I think the other point, though, is that when you are thinking about consolidation or maintenance, you really have to think about any added toxicity costs. Can these treatments be done in the salvage setting? Because the other side of that coin is that some patients are cured with chemoradiation. So all this added treatment is just added toxicity, burden, and cost. With that being said, I totally agree with the prior speakers. I think although the trial did not meet its primary endpoint, the PFS of Atezo, anti-TIGIT versus placebo, and because of that, it may preclude additional statistical testing. I think the potential benefit of Atezo monotherapy and the improvements in PFS and OS compared to placebo, I think they are promising and merit additional testing. I think some details that I want to see that hopefully will come out as we learn more about the study is first details regarding chemoradiation. This was a global trial, so there probably is some variation in how these patients were treated. We obviously want to see biomarker stratification, obviously PD-L1, but also TIGIT, tumor, mutation burden, other things. I think better data on toxicity and cost. I think we want to see what the long-term outcomes are. Is there durability of benefit in OS? Any delayed toxicity with combination of radiation IO, which we do see sometimes in practice. So I totally agree with the prior speakers. I think promising, needs additional data and longer follow-up, and hopefully we'll see that.
So let's wait for the additional data and longer follow-up. So, Erman, you want to make a point? Please go ahead.
I want to say something. So thanks so much for the discussion. So in the last ESMO GI, a subgroup analysis of rational trial of tislelizumab plus chemotherapy was presented for locally advanced subgroup of patients. So in the metastatic trials, also chemoimmunotherapy is also investigated in these studies and included locally advanced patients. And there also the Tisla plus chemo showed a significant benefit in hazard ratio around 0.5 or something like that. So it's quite looking like that the immunotherapy is working in this situation. So I think these results are supported by this study also. So whether just only chemo-IO or chemoradiotherapy after immunotherapy. So I think this will be a future question.
So let's wait for the further data. So moving on, now from the negative trials, let's get to the main story of the ESMO Matterhorn trial. It's a global phase 3 trial, Durva plus FLOT versus placebo FLOT, almost 950 patients. And they presented with the final overall survival hazard ratio of 0.78. And at 36 months, OS was 77% versus 68%. So statistically significant, clinically meaningful. And if you look at the subsets, the OS improvement, yes, it held regardless of PD-L1 status, but the PD-L1 less than 1%, if you see the confidence interval is crossing unity. Now look at the EFS curves by nodal status. They show consistent improvement, but again, we look at the confidence interval, especially for the node negative, It's crossing well unity. So given this, let me ask Dr. Udhayvir, will you use DFLOT in PD-L1 negative patients? I know you'll use it for PD-L1 positive for sure. What about PD-L1 negative?
Yeah, I think this is a really controversial topic.
That is why I asked you.
Recently, the Ankh brothers hosted a poll, and I think it was 50% yes and no. And I think this trial had 10% PD-L1 negative tumors, and if you look at the hazard ratio numerically, it was similar to PD-L1 positive, but of course the confidence interval was wide because of the sample size being low, so the study was not powered to look at that. But with now the overall survival improvement, I think it's really hard for me to say I'm not going to be offering it to patients with PD-L1 negative disease, but I will discuss a caveat that perhaps the magnitude of benefit is not going to be as much, but I will definitely offer just because the jury still is out.
Yeah, Dr. Erman, you agree or you have some different thoughts?
Well, indeed, I'm in favor of not giving because there are several reasons in my perception, at least. Because in metastatic setting, we know that the gastric cancer is the benefit is dependent on CPS score in metastatic setting, and in the supplementary material of the original publication of Matterhorn in the English Journal of Medicine, there's a subgroup forest plot, and the magnitude of benefit increase proportionally from top score 1 to 5 to 10. So, and 2 years ago, not in this year and in the publication, but 2 years ago, they presented the PCR rates according to the PD-L1 status in ESMO Congress in 2023. And the PCR rates did not differ between the arms in the PD-L1 negative groups. So I think the sample size for PD-L1 negative patients is very little, and if you could study with this number of patients and with these results in a separate trial, we will definitely call it a negative trial. So I believe that there is not enough data to suggest for this group of patients.
What about suppose you use for PD-L1 positive patient and your patient ends up getting PCR post-op, will you continue Durva? Because in other solid tumors like say in TNBC, we see that the continuation of IO if the patient gets PCR is not as great. So what's your thought on that, Dr. Udhayvir?
I think again here we don't have that data. This trial did not use that strategy of like holding off on immunotherapy if the patient did achieve a bad CR. So I would continue. But yeah, I agree with you. We really need better strategies of like personalizing these decisions to patients based on their PD-L1 status and then bad CR after surgery. But right now the data is just not there.
Okay. So moving on, Dr. Nina. Now, you're the champion of the cross trial and the cross versus flawed debate. So we wanted to understand what is the current role of cross in today's era for adenocarcinoma GE junction, or we'll be tempted to go D-cross or cross followed by Nivo or maybe cross followed by Tizo. Why it's only the D-flawed? Why not D-cross?
Yeah, so I love this question. I think obviously initially after ESOPEC and now Matterhorn, the landscape and the role of radiation has changed for this disease set. I think we all acknowledge that. We know not all these patients require pre-op chemoradiation because the predominant form of recurrence is distant. So escalating chemotherapy is extremely important. That being said, I think radiation still does play a role in certain scenarios. And I'll just go ahead and quickly outline those. I think we have to remember, so first I'll outline if, scenarios where we're just doing upfront neoadjuvant chemoradiation, no initial chemotherapy. I think the first we have to remember, and sometimes I see people kind of forgetting it tumor boards, is that these were only adenocarcinomas in these studies, right? In ESOPEC and Matterhorn. So for squamous cell in 2025, pre-op chemoradiation is still a standard of care. The second is that, and this is a smaller population, of course, but if the patient for some reason is not a candidate for FLOT or DFLOT, but they can still get surgery, the NeoAegis trial, which compared ECF to cross, provides equipoise between those two regimens. And the third, it's a little bit of a smaller population, but for T2N0s, if you really have a T2N0, which is not going to be a patient who presents with dysphagia, but maybe a tumor discovered incidentally, I really do think, and without going into the details and the forest plots, but I do think that FLOT and DFLOT are probably over treatment. I mean, there's a question if these patients even need any neoadjuvant therapy in addition to surgery, right? So I think these patients may benefit, if you look at the overall picture, toxicity and whatnot, from crossover FLOT. And then the second question is, after initial FLOT or DFLOT, when do we consider adding radiation therapy? And I think there are really two scenarios that are related. The first one, which we do see more, is if the patient presents with initial very bulky tumor and they get FLOT or DFLOT and there's still a concern for R1 resection. Then I think adding a local therapy can increase the likelihood of R0 resection, which I think is very important. The second, I think, related to that is if a patient gets FLOT or DFLOT and then they have a poor response, either on imaging or on pathology, I don't think this is a hard indication for radiation, but you might just ask yourself, if they have not responded to the 4 cycles of FLOT, what is the potential added benefit of giving another 4 cycles in that patient? I don't think that alone should steer you towards chemorads, but it's certainly a consideration, at least when we look at the either radiographic or pathologic outcomes. Second question, so I'm not aware of any large randomized trials with the addition of immunotherapy to CROSS. I think, there is suggested preclinical data and meta-analyses, but those are very heterogeneous in terms of, the immune checkpoint inhibitor, the radiation regimen. So I think it's hard to know a definitive answer in 2025, the additional role of immunotherapy with CROSS. However, your third question of adjuvant nivolumab or adjuvant immunotherapy, I think there is a role for that based on the Checkmate 577 study, which, as I think a lot of people are aware, looked at adjuvant nivolumab after CROSS for patients who did not have a pathologic complete response. I think many are also aware that the updated result, the OS benefit, was not statistically significant, although the difference was 52 versus 35 months, but the p-value was like 0.1. That being said, the DFS was still significant, and it was like doubled. I think it was 22 versus 11 months. So I think, in these patients, there is still a role of adding adjuvant nivolumab if they've had CROSS, they don't have a pathologic complete response, given those numeric benefits and the statistically significant benefit in DFS. So definitely worth a discussion. There's obviously added toxicity with nivolumab for the addition of 1 year, but I think we do see benefits that are clinically meaningful, including in the updated analyses.
So thank you. Thanks, Dr. Dina, for this wonderful thing. So there is, of course, a role of radiation, and it will probably...
I don't need to get a new job yet. But
So
maybe soon.
So let's move on, and thanks for this. So moving on, let's look at this trial, CARES 009, and it is in the curative setting of HCC. It is a phase 3 perioperative trial from China. It compared Camry plus Revo for 2 cycles before surgery and up to 15 cycles after surgery versus surgery alone. They enrolled stage 2B, 3B, Child-Pugh A, HCC patients, and EFS of 42 months versus 19 months. Huge difference, hazard ratio of 0.59. So, Dr. Anant, there were a lot of questions asked. First and foremost, of course, it's an China-only trial, and whether it will change any practice outside for the rest of the world. Do you require 15 cycles of adjuvant component, toxicity? So what's your overall thoughts on this, Dr. Anant?
Yeah, so first, I think this is going in the way of most immuno trials, immune checkpoint trials in solid tumors, where the majority of the benefits are probably seen in the neoadjuvant setting. Your golden question on the 15 cycles of adjuvant, I have no clue. I think most of us would be concentrating on giving immuno in the neoadjuvant setting. The melanoma and the colon MSI high data is really good. So I think this goes with that. The other thing is that this combination probably works. They have very good data in the advanced setting as well. So if we are able to use this or similar IO plus TKI regimens outside of China and explore it, I think we'll have some good results, because the delta here is the quantum of difference is enormous. It's more than double the EFS, it's 19 and 40. So that's remarkable in, potentially resectable HCC. So that's something that we need to look at very strongly. Even if we don't have access to these drugs, this strategy definitely is something that we need to look at. And the final thing that, I saw that they give in China, they give adjuvantase. So I'm not aware of any other major region where they give adjuvantase. So I want to look at how much that actually contributes to the outcomes. 80% got adjuvantase. So that's something I want to look at in terms of how much of a role it played in these outcomes. But kudos to the investigators. Very, very robust data. We should explore the strategy further.
Fine. So let's hope that these drugs are available, and probably maybe a global trial will give us a better answer. So moving on, let's go to colon cancer, where the momentum is shifting towards neoadjuvant therapy. We have two trials, Foxtrot, which showed that short pre-op chemo is safe and feasible in MMR proficient. This is also, but niche 2 went further. In MSI high, they give Nivo plus EP, and look at that line. It is not an error, it is a straight flat line. That means DFS of 100%. We used to see these things in probably Hodgkin's lymphoma or those kind of blood cancers. But to see that in colorectal cancer is something which is definitely wonderful. Now, the question comes, we have the atomic trial, which was presented. So we know that the IO works in MSI high. The question is, will you give the IO before surgery or will you give IO after surgery? I put this atomic trial slides. This was presented in ASCO this year. It is not yet published, so we only have this much data. But, so let me ask Dr. Erman, you have an operable colon cancer, MSI high, and the access is not an issue. Will you give the IO before or after? Or maybe both?
So yes, I was saying that. So the neoadjuvant treatment, as we know, that it has some advantages. So if you give the immunotherapy when the tumor is in the place, so it works better in most of the tumors because of the immunologic stimulation and benefit last longer. So in niche trial, you use only 2 cycle of immunotherapy, but in the atomic trial, it's 1 year. And you also use chemotherapy in the atomic trial, but in the niche study, there is no chemo burden, and we know that the chemo is not working in this MSI high patients well. So, but we shouldn't forget that the atomic trial is a phase 3 trial, but the niche trial is not a phase 3 trial. As you said that although the curve is 100% and there is no, it looks like there is no additional benefit from any additional intervention, but if it works in the adjuvant setting, maybe in future it could be investigated that you give Nivo EP preoperatively, and then you continue Nivo as adjuvant treatment in future in after surgery. So this could be investigated in the future, I think.
So what is your preference, pre-op or post-op?
Pre-op.
Which is one?
Pre-op. Preoperative, yeah, niche.
Very operative. You want to go beyond. Dr. Udhayvir, what's your thoughts?
I agree with Erman here. I think the benefit seems to be more when the tumor is in place. And this comparison is, I think, much needed data that just reiterates that we need to play with the therapeutic vulnerability of the tumor. And the therapeutic vulnerability of MSI high tumors is immunotherapy, that they're explicitly sensitive to immunotherapy. There's also been discussions whether adding FOLFOX affects the fitness of T cells or tumor infiltrating lymphocytes, and therefore compromises the activity of immunotherapy. So maybe within the limitations of cross-trial comparisons, maybe we're not seeing quite those curves with atomic. But we all see those patients that come in with an obstruction and need to get an emergent surgery. And later on, we find out that these patients had MSI high tumors. In those cases, of course, atomic. And even there, you could question whether you really need to add FOLFOX. You could just give atezo monotherapy. I've discussed with a lot of my colleagues who see a lot more colon cancer than I do, and they're all giving atezolizumab monotherapy in the right patient population, like older, frail patients. But if you ask me if I have the opportunity to offer any therapy preoperatively, I will go for niche.
So you are in the favor of preoperative. So this debate will probably continue, and we'll wait for the full publication of Atomic trial. Please note that it was presented in ASCO in June. We are almost about the end of the year. In November now, the trial is not yet fully published. So whenever it is published, I can get more information. So moving on, we have Pereira study, and what it did is that it tried to answer a sequencing question in the RAS wild type metastatic colorectal cancer, whether RIGO followed by PANI or PANI followed by RIGO, what is what. So whether VEGF blocker might resensitize for later EGFR therapy, what was the funda? And they found a modest benefit for RIGO first in cumulative PFS or disease control rates, but the OS difference was not great. So Dr. Amalya, how will you interpret this? So Dr. Anant first, how will you interpret this? And then Dr. Amalya, how will you fit this particular data?
Dr. Amol, if I could just add, I mean, you had briefly talked on Foxtrot. So just to ask the panel, since I have the opportunity,
yes, please.
How many of you are comfortable using the Foxtrot in resectable colon cancers? Are you convinced on the data in...
You're talking about MSI high, or
No, overall, Foxtrot.
Overall.
Since you mentioned it,
Yep.
in resectable colon cancer, T4B, etc., Monday morning, resectable patients come. How comfortable are you using it?
No, I'm not.
I'm not either.
Okay.
And I think across the board, even surgeons and us and radiation oncologists, I think tumor board discussions have uniformly been against using Foxtrot.
Okay, good to know that. Fine, right. Great.
So moving on, Dr. Anant, your thoughts
Yeah.
about this trial?
Yeah, so I
Then
think
we will ask Amalya to talk about this.
so the first thing is that numerically as well as in terms of usability, a better comparison would have probably been TAS 102 and BEV. I think so. We've had a lot of good experience with that. A lot of us now push regorafenib behind in our treatment options, though it is a valid third line option. With this kind of study, the quantum of benefits you would expect is exactly what you get. You're not expecting very large differences. So this just gives us an idea that if you use the whole neo-RAS, the RAS option when it's wild type, even in later lines of therapy, it's an option. But beyond that, I wouldn't read too much into the statistical differences in terms of outcome with this trial. It's just that if the RAS is wild later, use anti-EGFR. Beyond that, I don't read too much into this trial.
Yes, I agree with you. So Dr. Amalya, now they're trying to put this particular proposed sequence of treatment, first line, second line, third line. I just want your broad view, whether do you agree with this or more or less this is what you do in your clinic?
Well, it's difficult not to agree with Michel Ducrot when he's
Yes.
proposing. But I would like to stress here out that the first two settings, FOLFOX, FOLFIRI, upon preference, it's still interchangeable use, and the further lines is usually interchangeable. And I do agree with the sequence. I just missing here the part, the Stellar trial was also there, and we now maybe having also the Zanza data with the TISO. So Zanza TISO will also go a bit further and maybe will play a role in the after loss of Beva, probably. I would place it there. And I do still believe that immuno will have a role even in MSS cancer, not in the first line, not as much dramatic as in MSI high tumors, but still there are a few trials who are trying to combine with anti-PD-L1, anti-CTLA-4 plus chemo or VEGF. There are a lot of regorafenib, nivolumab data, and the novel ADCs coming away. So I think immuno will also have its role in the fourth, fifth line setting. Difficult to do in these settings, the trials, just because the tumor microenvironment is so exhausted. So we have to keep on mind that too. Maybe that's why our VGF is not working that well as it might work in the first line. But I generally agree. I will just add immuno in some places over there, like Sansa Tizo or Regora. I will add Nivo. And this is my take. For our clinic, I would difficult to test ctDNA a lot, but I do believe that when we are coming to third and fourth line setting, it's important to rebiopsy and to see how the tumor changed and evolved, because we are getting novel resistant mutations, and the ways to overcome the resistance are important.
So thank you. Nice to see that the colorectal cancer treatment is going up to the 6th line, and hopefully that will be good for our patients. So moving on, dynamic trial, and this is where the discussion becomes interesting. So to adjuvant colon cancer in ctDNA, so dynamic 3 randomized stage 3 patients to ctDNA guided adjuvant therapy versus standard adjuvant therapy, and they tried to see whether we can reduce overtreatment without compromising relapse-free survival. And what they found that after 47 months of median follow, 3-year RFS was 85%, was in the standard arm versus 88% of the DNA arm. So difference was 2.8%, but it was non-inferior, but the statistical design again was not that great. It was a non-inferiority trial, and then there was issues with sample size, design heterogeneity, false negatives, and T4 imbalance, a lot of issues with the trials. So these were, and it was very well discussed in this ESMO. And so let us ask Dr. Nina, finally, what is your take based upon this trial? When you do MRD for colorectal cancer adjuvant, do you do it, you don't do it, or do you escalate, de-escalate? What's your suggestion?
Yeah, so first of all, I realize I'm filling in for Dr. Kasi for this question, and we may have different thoughts, but I will share what my thoughts are on the subject. So I think we've seen time and time again that ctDNA in adjuvant colon cancer is prognostic, but its predictive value we don't know yet. So prognostic meaning if you're positive, your outcomes are worse than if you're negative. But we don't know if intervening, particularly escalating based on being positive, improves treatment outcomes. In fact, all the studies actually thus far suggest that they don't. I think, with those limitations being stated, I think what the study adds is that probably de-escalation, omitting chemotherapy for all ctDNA negative patients in stage 3 colon cancer is probably not safe. And I think most medical oncologists would agree with that. In the US, I practice in Dallas. We are in this kind of weird space where the test is available and covered by insurance, despite the data still being ongoing. So I actually interviewed one of my friends and colleagues, Dr. Kristen Siamber, on this point a while back. And I think she really said it best that it is really about shared decision-making with patients, kind of going over what is known and not known, and different patients may choose different things. And I think that's reasonable. But I think if you get the test, it's really one piece of the puzzle. So I think if it's negative, a scenario where I could think about omitting adjuvant therapy is if the patient's already a marginal chemotherapy candidate, right? If they are old, they're frail, you're worried about the toxicities, and maybe we're looking for a reason to omit it, maybe that negative test could sway you that way. And then if it's positive, I think I would emphasize that to the patient, they have a high risk of relapse. Certainly recommend the full standard treatment and then consider trial enrollment if there are trials assessing escalated chemotherapy for that setting. But certainly, I don't think the test is necessary to guide treatment decision-making 2025. So if it's not available, or if patients are needing to pay high costs out of pocket, I wouldn't recommend going to extreme lengths to get it. We have another ongoing trial, the Circulate North America trial, which is actually very similar to Dynamic 3, but it's a much larger sample set. Also in stage 3 colon cancer, that I think may address that question more definitively. So
let me ask you a very specific question. When you do these trials, are you happy with non-inferiority designs, or do you think such trials should have superiority design? Forget the non-inferiority.
Yeah, no, I talked about this a little bit. I think the non-inferiority is tough because and this was one of the criticism of Dynamic 2 as well, that it is a pre-specified margin, but and they go over their rationale for making that margin, but it is somewhat, consensus driven and maybe different based on where you're practicing. And, the margin's actually pretty large. If you think of the additional added benefit of adjuvant chemotherapy, it's compared to the margin's actually very large compared to that. And then the interesting thing about non-inferiority trials is that even if the point estimate is within the margin, but the 95% confidence interval falls outside of it, it's considered inferior. So I think there are nuances that make the results a little bit potentially sort of, less easy to interpret and less easy to understand. So I think that is another limitation of the study. Great question.
So anyone else has to have some thoughts on this? Dr. Anand, Dr. Erman, want to say something?
You're very exacting, Dr. Amol. To design a superiority trial based on something where you potentially want to reduce toxicity using the marker is going to be very tough.
Yes.
So, I think a larger sample size, and they might have hit the boundary, gotten within the boundaries. And I think the Circulate North America might get there. I don't think the superiority is going to help or, will be superior. That's what I feel.
Okay. So moving on now, we have COMPETE trial, and let's go to neuroendocrine tumor. And Dr. Udhayvir is expert in neuroendocrine tumor. He loves them, right? So let us try to understand this particular trial. And they've used this PRRT versus everolimus in well-differentiated neuroendocrine tumors. 300 patients were enrolled. And it's supposed to be a first PRRT versus active drug phase 3 trial. And the results were good. Median PFS was 23.9 versus 14.1 months. Hazard ratio is 0.67. And it is consistent across the subtypes of the NET. It was well tolerable. So now we have plenty of trials in this particular space. So Dr. Udhayvir, how will you go through this particular? There are so many trials, NETTER-1, NETTER-2, COMPETE, COMPOSE. So, and well-differentiated neuroendocrine tumor may not be that aggressive. So how you tackle this?
Yeah, just a small correction, Dr. Kare. I think this is one of the first trials that is looking at PRRT compared to targeted therapy, but we've had NETTER-2 that has compared PRRT upfront with somatostatin analogs, high dose, which is an active drug. And I think the big question has been sequencing of therapies. We have several trials now looking at somatostatin analogs, PRRT. We've had separate trials looking at chemotherapy and targeted therapies. But where do we sequence these therapies? And I think COMPETE trial is really one of the first studies that is alluding to the favorable sequencing of PRRT up, like earlier the better or sooner the better. And there are multiple reasons why it becomes very difficult for us to give PRRT later line compared to earlier. Loss of somatostatin receptor expression in some patients. Some patients undergo grade transformation. Some patients may develop more peritoneal disease, and we worry about complications and whatnot. And even from a therapeutic efficacy and safety perspective, it seems like when you compare to everolimus, which I think is a wonderful comparator arm here, it shows that there is better disease control, better response rate, which is not surprising, and also better tolerability. So it really reinforces our growing and evolving understanding that the sooner we use PRRT in the right patient population where you think that intervening with PRRT is something that you would consider and offer to the patient, that's the way to go. Now, you alluded to some other clinical trials like COMPOSE, where they're comparing in grade 2 and grade 3 GEP-NETs, they're comparing PRRT with chemotherapy, which is going to be dealer's choice, either Captem or Folfox, or you could also go for everolimus. And that'll also show if PRRT is even better than those therapies and should be prioritized. So I think this is welcome progress and is finally we're putting pieces of the puzzle together in terms of sequencing therapies in advanced neuroendocrine tumors.
But won't you like to wait for the OS, or you're happy with the PFS?
So that's another huge controversy in neuroendocrine tumors. Using OS as a primary endpoint in neuroendocrine tumors is really challenging. Number one, a lot of these patients have indolent disease, so designing clinical trials with an OS primary endpoint is almost impossible. The other thing is a lot of these patients will either cross over to the investigational arm or get the a similar drug or the same drug post progression once they're off of the clinical trial. So it's really hard to demonstrate an OS benefit, and for the longest time we've considered PFS as a surrogate for overall survival in neuroendocrine tumors. I know how that might irk people who primarily deal with other kinds of more aggressive neoplasms, but I don't think I'm going to be waiting for overall survival benefit here. And even if there isn't one, I would still see this as welcome progress and positive trial.
Fine. So thanks for your frank opinions. So moving on, come to the last few trials, Stellar trial. And of course, it tested the new drug, the Zanza plus Atezo versus regorafenib refractory MSS stable metastatic colorectal cancer. It has large population, almost 900 patients, dual primary endpoints, OS in overall population and OS in non-liver metastatic subgroup. Then the median OS was, in the results, if you see, 10.9 months versus 9.4 months, hazard ratio is 0.80, PFS was 3.7 versus 2, again hazard ratio is 0.68. There were some toxicity issues. So they are saying that this can be a chemo-free regimen. Of course, the magnitude of benefit for OS 10.9 versus 9.4 is not great, according to me, honestly speaking. So what's your take on this, Dr. Erman? Are you excited with this particular drug, 10.9 versus 9.4?
Yes, so in it, they presented that this is the IO-based treatment, the first IO-based treatment in microsatellite stable colon cancer. But I think that this study is not answering the question of whether an immunotherapy is working in this microsatellite stable colon cancer or not, because we don't have a control arm with only Zanza, and we don't know the difference between Zanza versus regorafenib or Atezo Zanza versus Zanza monotherapy. So in the phase 1 trial of this Stellar trial, it was Atezo plus Zanza versus Zanza, but it was just only phase 1 trial, and the benefit was looking in the non-liver metastatic patients. So I think this study is not answering the benefit of IO. And also, it's the most of the patients received it in the third line. So now we have better third line treatment than tripacil plus beva. So I'm not sure that the control arm is good or not. And the grade 3 toxicities are high in the treatment arm, and also cost is a problem. So I think, as you said, that the clinical benefit is not that big. So I think we need more data and or maybe biomarker for that.
So it has produced a lot of excitement, but as I agree that we need to see the longer follow-ups and see whether it really has a long-term benefit. So let's wait for the more data. And moving on to the last study that we're going to discuss, Checkmate HHW. And the question comes, we all know that the IO works in MSI high metastatic colorectal cancer. The question is whether the 2 IO or 1 IO. And of course, the Nivo EP versus Nivo showed an OS benefit. And then comes the question that to all the medical oncologists, which always face, to whom will you give doublet and to whom you single agent IO in advanced colorectal cancer, MSI high? So let me start with Dr. Anant. What's your take? You have for 2 drugs with toxicity, or 1 drug is good enough for you?
Yeah,
Or you're impressed by this particular OS curve?
Yeah, so I'll give you a third option, which is relevant to us. You probably are aware of it. So I think these are really great curves. There is no doubt on that. And they probably, I don't know about all of you, but I think the quantum of difference was more than I thought, more than I expected. A 3-year difference or a 4-year difference of 13% is actually fair. We would be happy with that across tumors, not just in this. I wish I
But
could
what
tell
about the
you.
toxicity? I
Yeah, I
the
was coming to
toxicity
that.
here.
So I wish I could tell you I could identify these patients in whom I'd be happy with a single drug. I don't know the answer to that. In patients in whom who can afford this, I would definitely give this. I have no doubt in my mind. The curves are very good. One thing that we have used often, and this is probably not very relevant to all parts of the world, is we've used a lot of low dose Nivo. We have early outcomes with that, and they are pretty good in terms of at least 1 to 2 year outcomes. So, if I had to reduce toxicity and give both drugs, I would probably give low dose. This is barring trials, of course. This is outside the space of trials. So if I have Monday morning patient, I would use the combo, irrespective.
Okay, so Dr. Udhayvir, what's your thought if you look at this curve for the OS in the first 3 to 6 months, 6 to 9 months, it is not clean curves, clean separations. What's your thought? Are there some patients who definitely requires double IO, or some patients probably are okay with single IO, and we don't know who are those?
Yeah. So if you compare the original keynote study with Pembro and data from Checkmate 8HW, 30% of patients will develop progressive disease with single agent IO. And if you look at how many patients will actually develop progressive disease with Ipi and Nivo, it's about 10%. So maybe using dual checkpoint inhibitor really gets those 20% patients that will develop quick progression with IO, and we've certainly seen those patients. And I think it's important to recognize that we club these patients together, MSI high or mismatch repair deficient, but this is a heterogeneous patient population. This is not one type of cancer. There's more data from Scott Kopetz and colleagues published in Nature recently, where they looked at differences in the transcriptomic profiles of tumors that may or may not benefit from the doublet. And they found that the more inflammatory the tumor was, the more likely it was to benefit from Nivo and Ipi. So maybe coming up with such biomarkers to inform benefit of dual checkpoint inhibitor versus ICI monotherapy would be welcome progress in this area. But I would agree with these data showing remarkable and durable benefit. I am inclined towards using Ipi and Nivo over pembrolizumab or nivolumab.
Quick word from Dr. Amalya and Dr. Erman. 2 drugs or 1 drug?
Okay.
You're a medical oncologist. Everybody is looking at you.
So here, there is one answer that I think everyone would agree. If there is a very frail patient, very old, you will be more afraid to give the doublet, though it depends. And in the trial, it's usually COG-IC 0 and 1, while in the clinic, we might see a worse condition patient. So this would be the condition we will think of the monotherapy. I do agree with everyone that doublet has better response rates, better results, and whenever possible, we'll try to give it, especially it's young, it's fit. We do also have the same issues with the cost, and we discuss with the patients a lot what to offer them and how to compromise the efficacy. So sometimes because of the toxicity, we do Ipi-Nivo start, but Ipilimumab not up to 4 doses, but a bit less, because it's still giving the benefit of anti-CTLA-4, and the cost will be less. And with the toxicity management, we did have an expanded access program of another anti-CTLA-4 and PD-1, which we were using in our clinical settings from different company. We were using it with infliximab, so we were reducing the toxicity. I know that there might be compromised efficacy as well, but the data is still supporting the better efficacy and better tolerability. So we just need to understand how to manage the toxicity to give the doublet drugs. So I would look forward to see the clinical data to understand maybe we need rapid response. So we want to go on the monotherapy or the fit patients, and this will be another strategy, as Dr. Grewal said. There are reports on the signatures and to see which patients do benefit more from the doublet, because anti-CTLA-4 is a bit different and it did affect the outcomes. but we look forward to see what other things as well. So in our clinic, whenever possible, we will give, but to the frail patients, to the elderly, to the one who cannot afford and will have only, I don't know, money for a few months of the doublet, we will favor the monotherapy for a longer duration. And we will be, of course, very aware of the early progressors. So we need to identify them as well.
Dr. Erman, your last thoughts.
Yeah,
before you
so
wind
in
up.
my opinion, I think Pembroke can be a option, but if you choose to use Nivo, it should be Nivo EP, I think, because in other tumor types also we have examples that Nivo monotherapy is not working, but Nivo EP combination is working. So I think if you choose Nivo, it should be Nivo EP as a combination. But I think Pembroke can be another option.
So I think we had come to the end of our panel discussion. In fact, and I thank all my faculties who have come across the globe. I thank Dr. Nina. She has taken time out of her clinic. And I'm very sorry for the goof of the time. I thank Dr. Udhayvir,
The
Dr. Amol,
daylight savings confused me. So, next time we have to account for that.
and Dr. Sawyer, and all the delegates. We have still more than 100 people listening to us. So the recording will be available, and I hope we will keep on doing such kind of educational academic activities in near future, probably post ASCO GI also. So I thank all of you. So good morning, good afternoon, good night, in whichever part of the world you are. So see you till the next meeting. Thank you. Thanks.
Thanks, everyone.
Bye.
Thanks.